Hello, my name is Andrew Kaunitz, Professor and Associate Chair in the OBGYN Department, University of Florida College of Medicine, Jacksonville, and a member of the Nams Board of Trustees. I have no disclosures relevant to this video in which I review endometrial sampling, a brief office-based procedure important in managing certain menopausal patients. Vaginal ultrasound is playing an increasing role in evaluating midlife women with abnormal uterine bleeding. Nonetheless, endometrial sampling continues to be appropriate for selected patients with postmenopausal bleeding, perimenopausal women with prolonged or heavy irregular bleeding, women with cervical cytology findings of atypical glandular cells of unknown significance, or AGUS, and finally, follow-up of women with a prior diagnosis of endometrial hyperplasia. Prior to proceeding with endometrial sampling, I discussed the indication for this procedure with my patient, explain relevant anatomy and instruments, and ensure that they understand that intense transient uterine cramping is likely. Although I do not routinely pre-medicate patients, it is reasonable for women to take a non-steroidal anti-inflammatory drug 1 hour prior to sampling. If it is not clear whether or not the patient is postmenopausal, a urine pregnancy test should be performed prior to sampling. Endometrial sampling devices I use employ a disposable plastic cannula approximately 3 millimeters in outer diameter. In pipelle-style devices, suction for tissue retrieval is generated by an internal piston. In contrast, the Explorer-style type of sampling device, which generates more suction, uses a syringe attached to the cannula. I find that systems like the Explorer, which employ a semi-rigid curved cannula attached to a syringe, more readily pass through the cervix and generate a larger volume of tissue than internal piston devices with straight cannula. After performing a bimanual exam to assess uterine size and position, a vaginal speculum allowing good visualization of the cervix should be placed, and the cervix and upper vagina should be prepped with an antiseptic. In most endometrial sampling procedures, I do not use local anesthesia. However, when cervical stenosis is present, I place a total of approximately 5 cc's of local anesthesia around the os into the cervical stroma using a 25-gauge spinal needle at 4 injection sites. To facilitate placing the endometrial sampling device all the way to the fundal component of the endometrial cavity, I routinely use a cervical tenaculum for traction and stabilization. Use of a fine single-tooth tenaculum, such as the Goldstein Grasp tenaculum, marketed for use with saline infusion sonography, causes less pain and bleeding than conventional tenacula. The endometrial sampling device should be placed through the cervical os until the fundal component of the endometrium is felt. While applying suction, the device should be rotated within the cavity while slowly withdrawing the device. If suction is lost prior to obtaining an adequate specimen, repeating the procedure with a second sampling device may be appropriate. When cervical stenosis is encountered, the use of the use of fine 1 through 4 millimeter cervical dilators facilitates endometrial sampling. Endometrial sampling devices are calibrated, and clinicians should record how many centimeters the cavity sounds to. If a cavity sounds less than 5 cm in a menopausal woman, this suggests the device did not sufficiently enter the cavity and that alternate approaches to endometrial evaluation may be indicated. If the fundal component of the cavity is reached and suction is maintained while the device is rotated within the cavity for some 45 seconds, endometrial sampling is highly reliable in excluding malignancy. However, this test's ability to exclude malignancy is by no means 100%, and polyps as well as focal malignancies can be missed. Some patients will experience vagal reactions following endometrial sampling. Accordingly, the patient should remain recumbent for several minutes after the procedure is complete. After a biopsy with benign findings, if patients continue to have abnormal uterine bleeding, or if such bleeding recurs, performing a sonohystogram or hysteroscopy is appropriate to exclude endometrial pathology. For clinicians who wish visual detail, the New England Journal of Medicine has posted a video demonstrating endometrial sampling on YouTube. Thank you.